session, that is a case-based discussion part. Here I would like everyone to know that format of this session is different from the rest. So here we will test our overall understanding and take home points of this workshop, and we will discuss some real life case scenarios. And during this session, one of my colleagues will present a case and then we can have an open discussion about this. So the format of this session is that the speaker will be given 5 minutes, and after the next 15 minutes we will utilize for discussion. So I request everyone to come with great zeal and enthusiasm. And finally, for conducting this session, I am immensely pleased to welcome on the dais Madam Adarsh Kohli for moderating the session. Dr. Adarsh Kohli is a former professor of clinical psychology in our department, and as you can see that ma'am has overseen multiple projects and ma'am has a number of awards and papers to her name. So over to you, Adarsh ma'am, for the moderating the session.
Yes.
We have 3 cases, and each of these cases are going to be dealing with a different aspect of abuse. What we saw was that though the subject of sexual abuse looks more, people are getting more emotionally involved, but there are things like physical abuse and emotional and psychological abuse which is not apparent but leads to deleterious consequences. So the cases that they have chosen were actually cases in the psychiatric ward, sometimes in the ward and sometimes in the and how they presented and what were the aids that were used in assessing, in identification, and how they dealt with them. So we're going to spend less time on the presentation and more time with questions and with actual cases and your questions about how to deal with the case and what really happens, what could be the causes, what are the other kinds of abuse that were apparent in the case. So I'm inviting the first speaker to come up with the first case and apprise us of the details.
So case statement 1, 7-year-old female child, 3rd standard, belonging to Hindu joint family, middle socio-economic status, rural background and a resident of Himachal Pradesh. So chief complaints were बात कम करती है, डर जाती है, पढ़ाई में मन नहीं लगता. Present history: during the COVID lockdown, child began to live in her ancestral home with parents and parental grandparents. She was noted to spend all the day playing outside with her brother and other children. She was also allowed unrestricted phone usage. Over this period, parents began noticing fearful and withdrawn behavior with decreased sleep and appetite. She lost interest in attending online classes and would remain aloof. Gradually, she refused to go outside to play with her friends in neighborhood, and she started having short spells of laughing and clapping by herself. Then she appeared fearful and said कि भूत दिखते हैं, and she would respond to questions in single words. She began repeating questions asked to her. She also started passing urine on the bed while asleep. So referral for psychological assessment was made as there was no stresses in the case history. So here the rationale for psychological assessment would be diagnostic clarity, conflict assessment, and indication for any kind of abuse, neglect, or any other stressor. So can you tell that what kind of psychological tools can you use in this case? Yes.
करेंगे और फर्स्टली रैपो बिल्ड करेंगे उसको, फिर हम उससे कुछ कलरिंग भी करवा सकते हैं, जैसे ड्राइंग फैमिली या फिर कुछ वैसे इंडिविजुअल उसे कुछ ड्रॉ करने के लिए दे सकते हैं. या फिर एक जो टेस्ट होता है कैट, अगर वो थर्ड क्लास का बच्चा राइटिंग कर सकता है तो उससे स्टोरी भी लिखवा सकते हैं। तो एसोसिएट विद द एनवायरनमेंट, वो जो भी उसके मन में है या वो जो भी सोचती है वो उसमें बाय द प्रोजेक्टिव जैसे टेक्निक है उससे वो एक्सप्रेस कर सकते हैं।
Thank you. So the overall psychological tools include play observation for younger children is very important, drawing test, incomplete sentence test and content analysis test, CAT, PET, etc. and picture test. So we here did the play observation in this case. During play observation sessions, the child was allowed to explore the playroom and then child was provided safe and comfortable environment without any judgments or suggestions. She picked Barbie doll and Motu Patlu stuffed toy and removed clothes particularly from the area of breast, hips and vagina and touched them repetitively. So in following sessions, she made story enacting one doll and verbalized, ये नहाती है, कपड़े पहनती है, टॉफी खाती है and pastry खाती है. In further play sessions, she made story from male doll and female doll, taking name of each boy and a girl, and then enacting them that they साथ रहते हैं इस घर में, romance करते हैं, and she enacted male and female dolls kissing each other. In further sessions, she made story of getting them married. So can you tell any indications what this play observation gave us?
Ma'am, was she? So sorry. Yes, I can tell you.
Yes, ma'am, please continue.
Was she sharing a room with her parents and she's probably seen them?
What this play observation indicates? What are the indicators in this play observation?
So the question that you are asking is a general question. Maybe in the inquiry we can take it up. But the play observation which psychologist has done, we want you to ask us about the content of the play observation, what really it showed.
Yes.
Highlighting the parts of the body that is vagina, where somebody has touched her there.
Okay.
Who is the person?
Okay.
Yes.
Ma'am,
What
may I-
else? Right.
I would like to explore it a little more. Firstly, I would like to adopt few techniques of maybe venting and validating for her to open up more so that I don't jump to conclusions, and maybe like what Sir said, like adopt scaffolding techniques where we can understand whether she was, because I'm in doubt here, whether she viewed such images from somebody or was she a victim. So just
Yes.
using play therapies and further getting into more other therapies to come to know.
also maybe what they say, rescue and remove. Maybe remove her from that scenario and try to understand whether make her vent and validate her feelings in a different scenario.
So in this play observation session, we first came to know that there is indicators like this, maybe CSA witnessing or witness or victim of the CSA. So next we thought that what are the other psychological tests that could be corroborate the findings, because play observation or any other test are not diagnosis towards CSA. So can you just elaborate or have?
No, we added some more tests and you can show us the tests.
So we, yes, DAPT, because 7-year-old child, so we chose the DAPT test. The child drew girl and then boy. She connected both and said, "Inki shaadi ho gayi hai." So any indicators, if you will know. So there are indicators that omission of arm suggests guilt feeling in girl figure, and omission of neck suggests impulsivity and regression in both. And then this was the drawing, another drawing of DAPT. Here omission of nose and withdrawn nose shows that withdrawn and emotionally disturbed. Omission of arm suggests guilt feeling, and overall nude breast and emphasis on waistline may suggest sexual preoccupation and may sexual conflict. So this also corroborated the findings. So next we use some sentence completion test. Here one of the sentence she made like मैं चाहती हूँ कि कोई आदमी मुझे किस ना करे. So we got leads of inquiries for further corroborating these findings with the case history. So can you suggest what kind of abuse?
That's obvious, of course.
No, over to you.
So now you can ask us questions regarding the case, regarding the, what happened after that, and probably the senior resident on the case in chairperson, because somebody said that one has to go about in the inquiry. All these are adjuncts to interview, so they're not really diagnostic and they're not really leading us to diagnosis. But we take the help of these psychological tests to actually conduct an interview, which may be non-directive, which may be play therapy, and during play therapy we take up various issues that also various kinds of play therapy are there. So whatever questions you have, you can ask us, and if you want to know about the case, that they'll be able to tell you. Yeah.
I actually wanted to ask that if the child witnessed somebody indulged in a sexual activity or something happened to her, because the marriage drawings and all indicate that she has witnessed somebody else doing it.
So when we elaborated the case history and interviewed many family members, so it was apparent that she was the victim by the older child. They were playing together most of the times outside the home, which I mentioned in the history. So her brother also was there. So brother also reported that he witnessed that something happened and the girl was crying and was fearful on that day, particular day. So something had happened with those other children which were elder to her. Any other contribution, inputs or anything? This is open session, so you can.
I have one question. How many sessions does it take you as a psychiatrist or a counselor for a 7-year-old child to maintain that rapport that she comes off with her candid report?
In general, it depends on child to child.
There's no set. We can't give you an answer that these many sessions. Some people think that counseling is one session. Generally, what I am experiencing now is, the counseling karwa ke aa jao just means one session. It may take a couple of sessions, it might take a dozen sessions, it might take more. Depends on your expertise of rapport building, your expertise of exploration, your expertise of confidentiality, your keeping your ethical standards, and how easy the child is with you. And also, not only exploration, then resolution of symptoms, and finally, the therapy which really happens. So it might take 10 sessions, it might take 15 sessions. There are no set rules.
I'd like to ask you, I think the counselor and the client are finding out how easy is it to deal with the parents, the caregivers who get a child, and they're sometimes from such small, from such remote areas that it is not conducive to carry on those sessions for them, maybe after one or two sessions. So does that hinder therapy?
Generally in child guidance clinics, we see that there's a very poor follow-up. And mainly because of logistic reasons, financial reasons, distance, and not because of, mainly because of financial reasons. They do understand, but they're unable to come and they're unable to take sessions. That does happen, and that's the most difficult part. Dealing with parents, aware, unaware, that's the most difficult part.
And do you have certain common tips to give to, let's say, not so aware parents or not so aware society?
We try to manage, whenever the case comes, we try to handle it that, because we did decide that if they don't come back, then we should have one package that we can just sit and talk to them and tell them, after your case is discussed, you can come back and meet us, and we can give them some tips and we will make them aware. But it doesn't happen every time. There are logistic sometimes the patient gets late or doesn't come back, but that is
there
the
parental acceptance of the situation?
there's no generalization to this. Maybe a poor patient can also have acceptance and a rich patient also may not be. They don't come also, they don't realize also it's a
interviewing the parents and disclosing them is also an art. You can not just say that this has happened. You have to take leading questions and then so that they can also realize that something was there but we didn't realize in the past. So these are the steps which we have to follow with parents also, gradual steps to disclose and to interview also.
You mentioned one of the symptoms was laughing and clapping. So what did you interpret from that, and how did you manage it for the session?
Yes, that is the last question. What was the consequence? So yeah, initially the case was diagnosed as depression and then gradually we saw that the trajectory moves towards the bipolar disorder in 7-year-old. So CSA can lead to so drastic change or in the and consider it as a bipolar. So it was a very surprising thing. So initially we did play therapy sessions for depression and irritability and clapping, and both we thought it is a regression, it is a part of regression currently. But afterwards it also turned to the episodes of mania, and then so pharmacological also treatment also took a role, and play therapy sessions and dealing with parents continued.
apart from other things, it can lead to a range of psychological issues, it can lead to physical symptoms like people commonly told you. But then it can also go on to psychosis and severe mental illness. So that can be the long-term follow-up of these cases and what it leads to. So this was one of the things that even I was not aware because I'm not in the department anymore, but they told me that it went on to bipolar. It turned out to be bipolar by the end. And how much time did she spend in the ward?
2 months.
2 months? Any more questions? There are something else. Quick one.
Was it a mixed episode or was it mania or depression? And was CDRS done?
Next episode, it was started with depression and then mania, shifted to mania.
One last question. We do not going on to the second one.
Sir, wanted to ask, were we able to find out what exactly happened?
We could find out with the help of the brother and observation of the parents. We could find out this what happened exactly to the what incident happened. But to having an evidence was difficult because the child turned into the child didn't reported us to directly, but we have collaborated all these findings to establish moreover role of CSA and treatment related we could establish. We could gain so much information that we can collaborate it into treatment work, pathological and non-pathological both.
Thank you, ma'am. We'll now move on to the next case, and for that I will invite Dr. Prashant.
Good evening, everyone. This is another case that we try to handle. So, the child is a 7-year-old male, second standard, belonging to Hindu extended family. He belonged to a middle socio-economic status. He lived in a rural background and was a resident of Uttarakhand. And his chief complaints, as per the parents, presenting over a period of 1 year, was being aloof, smiling to self. He started showing aggressive behaviors and also had poor academic performance over this time. The course was continuous and it was progressing, and the onset we understand to be insidious. So this is the history of President illness. The child was raised with maternal grandparents right from the time of his first year of infancy. He had a normal development till 3 years. By 4 years of age, he shifted and began to live with his parents. The situation was such that the mother had job commitments in another location, so father, along with his extended relatives, were the primary caretakers. So initially, in the first 3 years, he had developed secure attachment with his maternal grandparents, and later, during the course of time, he spent with his father along with the father as well. But his father was very strict and rigid, such that any behavior he did not approve was met with a very stern response and occasional physical punishment, even to a child of around 4 years. So this was very much in contrast with the way the maternal grandparents handled it in the first 3 years. So the child was then, by history, we were able to get that he was becoming anxious around the father during this time. Now then happened COVID lockdown in 2020. Due to the parents' job commitments, the father was actually a veterinarian by profession, so he could not stop his work, and mother was still held up in another place. So again, due to the circumstances, he was again shifted back to his maternal grandparents' place. Here again, being with them again made him comfortable, but the overall prevailing pandemic situation made him a lot of sense of uncomfortableness, and he was nervous due to these pandemic-related news and situations. After a year of living with the maternal grandparents, again, abruptly, he was brought back to live with his parents, as again the maternal grandparents had to attend to their son who was sick in another city. So again, the child began to live with both parents. Here, mother again had taken leave due to the situation. She came back to live, and the mother and father both were there with the child. Mother was also available most of the time, and as we could gather, she was very soft-natured, but she had a tendency to worry a lot. Often, because of this, the child did not feel secure in the presence of the mother, and also because he was never really used to the mother. During this time, his father became very sick, and he was admitted in a critical condition after the COVID infection. He was in the intensive care. And again, concurrently, the child and mother were also infected by COVID, but due to the less severity, they had to just endure an isolation together while the father was admitted in a critical condition. Now, around this time, the child would become more and more restless. He would start repeatedly asking about the father's condition. And mother, being a person who tends to worry a lot, she became much distressed, and she started having frequent panic attacks in the presence of the child, causing more sense of threat to the child. The child became more aloof during this time, and he started showing reduction of interaction with all of them, even after the end of the isolation. Eventually, father recovered, and the child reunited with him, and again he was now gaining back, slowly improving. He started to, by this time, get comfortable with the mother's presence as well. And after a few months, mother now, at the end of her leave, had to go back and rejoin the location where she worked. And mother had to leave him because of her commitments, and as soon as the mother left, and father was also equally working, so most of the time he had by this time started spending with the mother. And as soon as the mother left, he again started showing symptoms of being alone, and a lot of times he would be seeing self-absorbed, lost in his own thoughts. He would now show poor regularity in his routines and would be unable to study as before. He also started to show odd behaviors of smiling and muttering to sleep at this point. Often these behaviors, as per father being a very stern person, completely unapproved, and he started to react to that very sternly and in a completely strict manner. Often this would lead to the father almost escalating to a situation where he would beat him harshly in an attempt to actually discipline him and stop him from doing all these kind of behaviors. And further, this went on to worsen the situation, and the symptoms of poor interaction, self-smiling, muttering, and inability to perform in academics amounted. And he then presented to us. So now I request ma'am to just look at these questions and we could address it too.
So what is the kind of trauma that was in the child? Huh? Okay. Separation anxiety. Okay. Can you stand up and say
First, what I could gather according to the experience that initially the child was staying with the grandparents for 3 years, then shifted to the parents.
Yes.
Then again the episode repeated, was again sent back to the grandparents, so this kept on continuing. Father was kind of very strict, so here like separation anxiety. And second, what I think is that of course the child is undergoing abuse also, emotional neglect by the mother, and father being strict. That again comes up to be physically, because he was kind of hitting and kind of screaming and yelling. So these are the things that was the reason.
I think even in addition to that, just the absence of a permanent in
in addition to that, the absence of a permanent and stable primary caregiver and house.
Exactly. Attachment figure that kept shifting from one person to the other. What else? Yeah.
Adjustment. He had to move houses again and again.
So that is
Physical
really,
environment.
Okay.
Mother's mental health also.
Mother's mental health also, because she was anxious. Yeah. She was anxious and she had panic attacks, and so part of it is coming from the mother, the genetic reasons.
एक्चुअली थोड़े से जैसे साइकोटिक सिम्टम है वो भी आ रहे हैं, जैसे वो सेल्फ स्माइल कर रहा है ना, और
क्या कर रहा है?
सेल्फ स्माइल कर रहा है,
स्माइलिंग टू सेल्फ,
जैसे वो सेल्फ स्माइल कर रहा है खुद में और अकेला रह रहा है, और जैसे बंटिंग का भी है उसका बिहेवियर, तो वो थोड़े कुछ साइकोटिक जिससे है वो भी इंडिकेट कर रहा है कि वो अभी जैसे सोशली विड्रॉल भी हो रहा है, नॉर्मल से जो एक रूटीन है उससे वो हटके कुछ अदर जैसे एक्टिविटीज है उनमें इन्वॉल्व हो रहा है, जैसे उसका बिहेवियर चेंज हो रहा है, तो ये चीज़ थोड़ा सा इंडिकेट कर रहा है कि कहीं ना कहीं कोई साइकोटिक प्रॉब्लम भी हो सकती है।
I also feel there is a lot of negative expressed emotions from the father figure towards the symptomatology that the child is exhibiting. There's a lot of expressed emotions and the physical.
Was it an expressed emotion?
Ma'am, the punitive nature of the father, he's trying to
punishment.
Ma'am, as a part of punishment, and he's trying to discipline the child's muttering behavior. I think it was mentioned. The self-muttering behavior through physical abuse, he was trying to discipline the child.
He thinks that if he's strict and if he's punitive, he might be able to
control that behavior.
Okay. Right. So you want to tell us what happened to the case?
At the time of presentation, the history would lead us to understand the foundation of post-traumatic stress disorder was initially fitting. But then there were a lot of symptoms which was actually a psychotic symptom that was also present in this case. So initially in the whole process we understood the parenting was the primary reason that a lot of work had to be taken. And initially the medicines were very less, although we started with psychotropics to increase stabilizing. But the main mode of treatment was again play therapy, and Dr. Dixon was very closely associated in the treatment. And as and when the play therapy started, most of his interaction improved. Most of those behavior where he was able to direct his attention to people started improving, but the self-smiling actually continued. So later on, we still found that the child went on to have a lot of psychotic symptoms, and other diagnosis also was demanded in this child, and he required an antipsychotic as well. And what happened interestingly was the parents, after understanding because of their good education background, they immediately started putting a lot of effort. They stayed with the child. Both the parents took leave and stayed for almost more than 2 months with this child, and a lot of attachment-based activities were initiated, and that showed a very good response with this child over a period of time, and he's in regular follow-up and he's doing well.
And they also took up the mother for treatment, therapy and treatment. Ma'am, you want to say something?
What the child mean of the psychotic?
He's still on a maintenance dose.
Can I ask you a question? In a case like this, I would be interested in knowing. I'd be interested in knowing in the child. I mean, we have talked about the environment, father, mother, family, and the circumstances. But what about the child? Did the child individually had any vulnerabilities in him in terms of what was the perinatal history, prenatal history, and immediately genetic contribution in the family history, and so on. So this has to be also kind of kept in mind and examined and explored, because every child is not, given the circumstances and condition, does not break down into a psychotic condition or such a severe level of psychopathology. We need to look at the individual specific vulnerabilities in the child himself also, genetic, biological, and environmental, and related to pre and perinatal factors.
One of the points that I had noted was mental pathology in this child, because any kind of counseling that was
empowered to communicate their feelings, like to be more expressive with the parent and with themselves, like journaling and to basically helping him in better emotional regulation, to identify his feelings and to express them accordingly, because in all this turmoil, I think the child was also able to tell the parents what was going on. I think that could also
help. Yeah, journaling his emotions and
yes.
I think also the child is young, so if he can properly put in some kind of physical activity, that's the best, not the best forms of letting the energy be out and a routine follow up. I think that can do wonders to this physical activity.
The history doesn't tell about his friend circle. Was he deprived of friends? Peer group interaction उसका पहले से कैसा रहा है, थोड़ा अगर हमें ये भी पता लगे, और अगर नहीं था तो उस तरफ काम करने की ज़रूरत है कि peer interaction भी बढ़ाया जाए.
Yes, firstly in this case, the initial 3 years from the grandparents' history showed a very good social development and social milestones. But what we also saw, the COVID played an important role, which is also an equally important contribution to the trauma here. And during this period of lockdown, he absolutely had no contact. And most of his milestones did not progress after a point. And again, a lot of his social skills, the age appropriate ones, did not continue to develop during this time. So currently in the intervention, firstly we did work with parents and we're continuing to work. A lot of communication patterns with the parent and child has been worked on. Interestingly, this child had a very good verbosity. He actually could express a lot of things, and that is when the neglect was very obvious, because despite all of his capacity, there was not much notable initially from the parent side. But now that there is a lot of improvement, he is back to school, and specific targeted physical activities, engagement in sports like badminton, hockey, things and all can happen.
Can we move on to the third one?
In case 3, we have a 13-year-old female who was an 8th class student from a Sikh extended family of middle socioeconomic status and urban background. The chief complains as per parents, पढ़ाई में कमज़ोर है बचपन से, स्कूल से शिकायतें आ रही हैं 6th क्लास से, क्लास में बेहोश होने लगी 7th क्लास से. As per adolescent, स्कूल जाना अच्छा नहीं लगता 7th क्लास से. In history of presenting illness, this child had a history of delayed cry post-normal delivery. Parents did not notice any delay in milestones or adaptive functions. She was admitted to a CBSE school at age 3.5 years. In primary classes, she needed extra help to complete her homework. Parents would repeat the lessons multiple times. At school, she enjoyed playing with friends and was good at art and craft. At home, she was obedient and would help her mother in household chores. Class 5 onwards, teachers began complaining that she is poor in all subjects. They suggested change of school. In 6th class, she was shifted to another CBSE school with fewer students. However, she was neither able to cope with the schoolwork nor made any new friends. Teachers would scold her in front of the class, and one of them even called her Nalayak Ladki. Some teachers would make her stand in a corner of a class as punishment. When she informed this family, they simply asked her to study harder. Issues continued and she was promoted to 7th class with pass marks. Once, in front of the whole class, a teacher told her, "तुम अपने घर वाले को पैसा बर्बाद कर रही हो." She began crying, but no one consoled her. Following this incident, she began having unresponsive episodes, lasting for 15 to 20 minutes while in the school premises. On seeing this, the teachers commented, "तुम नाटक कर रही हो." They asked parents to take her back home. Initially, she would tell parents that she wanted to go to school. But now at school, she would be made to sit separately. Gradually, other students started refusing to eat with her. And one teacher told them, "ये पागल है, इसे दूर रहना." Her unresponsive episodes at school increased to 2 to 3 times per day. She herself began refusing to go to school. School authorities informed parents that they cannot keep her at school anymore. Teachers asked for a certificate from the doctors. Parents who were worried brought child for consultation. Moving on to the questions. Has this adolescent experienced abuse? Yes. What kind of abuse is it? It's emotional abuse. What are the risk factors for this adolescent?
One by one. Yeah. What are the risk factors? Huh?
What were the inherent risk factors that this child had? Yes, please. Yes. She was having academic difficulties from the very beginning.
What kind of academic difficulties?
I think that,
think of?
sorry to cut you short, sorry. I think that first and foremost, because she was having difficulties in school for a long while, she should have been checked for having any specific learning disability or any intellectual disabilities or not.
Yes.
If we could have first found out that thing, because when you're having any kind of learning difficulties, obviously you will have problems in school, and unfortunately, because not a lot of people are very aware of how to deal with a child who's having learning difficulties, and we look at it as, we treat it as like tum nalayak ho and all that. So that is where all that differentiation between other children, other students, and using certain words to differentiate them as different from like tum nalayak ho and
Try to be brief, yeah, right.
Yeah.
We did explore for that.
So from their possibility, when the second, like that happened in the second school, the dissociative attacks started coming there as a result of whatever she was.
That's the history we are giving, so you have.
Yeah.
Can you please tell us the?
Yeah, the risk factors were in this trial.
No, not the risk factors. The intellectual what question?
The intellectual. So here we have already mentioned in the history that she was poor in all the subjects. So we were not we had explored for specific learning disability, but she was found to be poor in all the subjects, and so we had ruled that out. Intellectual capacity, we had done IQ assessment, and her IQ was 83.
Low average IQ.
Low average.
And poor in all the subjects. So therefore the academic decline. But we are still discussing the risk factors. What are the risk factors? One was the borderline intelligence and the academics. What is the other risk factor?
Can I ask you one thing? Did we rule out hearing and vision difficulties?
Yes. Yes.
After that only we will be going for the intellectual.
Yes, exactly.
Right. Loss of peer support. Because everybody was asked to stay away from her, and they said कि इसके साथ मत बैठो, ये पागल लड़की है ना? तुम भी पढ़ने में नालायक है, whatever. So expressed emotions, critical remarks, derogatory, demeaning remarks by the teacher, and isolation, ostracization, which we all that emotional psychological abuse. What else?
It could lead to suicidal ideations also.
It could lead to, yes, range of, we told you that it could be range of consequences are very detrimental. It can be right from emotional, psychological to psychosis. Suicide is one of the, what else? Yes. Peer and family, both. Peer and family. Somebody said peer, but nobody said family. Family also is not supportive. That's another risk factor. Nobody reached out to her, right? So she was isolated in school also when she was sitting separately. Yeah.
And the next question, what are the protective factors in this child? Yes, she was good at art and craft.
Good. What else? She was obedient. That's another protective factor. She follows instructions and she could, do what is told to her.
She was helping her mother in her household chores. And in the first school, she had made friends.
She was able to make friends in the first school. She was shifted to the other school. And there she faced more abuse. But she could make friends in the first school. So in an environment which was positive, which was more congenial, there she could make friends. So that is one of the positive strengths. That could be a very good, that could be an asset and strength which could take her forward and which could save her from abuse and other things. Okay.
One thing that I would like to add, which is very crucial, so I'm child who is to be addressed, जिसमें कुछ issues हैं, it's also about others, even the school system, the peer group, the family, everybody, to give that inclusion in the society in a mainstream. And for this, the peer group needs a separate sensitization program in which they need to know what intellectual disability and what this child is going through.
How far can you do it in a school, like in the where she came from?
Yeah.
Would one do?
This depends, like how far. This depends how far we can go. Until and unless we try it, we don't know where we can go. But at least giving it a try is very much important.
Some schools are responsive. Yes.
Yes.
They do respond and they do.
So the final questions are, what are the consequences of this abuse and how can you help this adolescent?
In this case, there was also, she refused to go to school.
School refusal.
School refusal with her, school dropout with her.
How can we help this adolescent?
Counseling, we can start in say therapy and start the interventions ASAP.
You can liaise with the school.
And the subject can be changed to customized curriculum.
Art and craft. Yes, please.
Psychoeducation for parents and teachers. Possible.
Maybe we can even provide one-to-one tuitions to this child.
And and we can think about one-to-one open school. She can go for subjects by turns, so that she's accepted better and she can be emotionally better and she can be there is no chance of derogatory remarks and no chance of criticism.
I think most importantly, she needed encouragement.
She needs encouragement, of course, through her positive assets which she has.
I think with her art and craft activities, we can create a very positive peer group for her, encourage her with social emotional skills to become more confident about handling a peer group. That's very.
And we could also deal with some coping mechanisms in her case, so that she can direct her energies in a place where she can do better. Everybody is not good in academics but good in other things, so she can always be directed. Make her more resilient also, right? With the coping skills only she can be more resilient and more positive. And she can be more acceptable, because once the parents see that she's doing good in other things, then they might be more acceptable to the situation. Any other suggestions?
Since she's cognitively not functional, we can help her understand. We can teach her basic grounding exercise, grounding techniques in case she faces something with parents and teachers. So certain grounding and visualization exercises can help her.
What exercises?
Grounding and visualization. Like she has to train over time, but she will eventually will be able to do it.
Certification also could be done in this case, so that she can get some benefit out of certification. Some concessions maybe can be offered to her. Some vocational skill after she goes on with like
during basic
10th and 12th.
During basic education, subject can be changed in school.
Yes,
This is
exactly.
the practical subjects can be.
Now we have flexibility of changing subjects, and we can leave those subjects and take up
And
subjects which are
benefit
more.
of CBSE.
Exactly.
Maybe we provide.
Exactly. So what are the really, if you want to talk of abuse of any kind, what are the protective factors? What can help a child? क्या अगर बच्चे में हो तो it's an asset to go get over their views.
So even in this case, I think one of the protective factors was also the fact that she had access to mental health services and medical
She had access
services.
to mental health facility and
So
counseling. and
just
everything.
about that, had the parents denied it and not gone there, she could have probably just gotten
That
worse.
would have ended up in other abuse.
Exactly.
not taking her to a specialist and not taking to a psychiatrist or a doctor or a counselor, right? And like somebody said, you know, if somebody is good in sports, somebody is good in painting, somebody has good peer group, somebody has good coping, all these can be protective factors in a child which could help. Good supportive parents. Generally I'm talking about this. So all this can help, you know, resolution of symptoms, getting over the symptoms and starting anew and starting something which can take you to more productive and more constructive kind of activities and trying to forget what had really happened. But then in this case, I think the parents also need to be counseled, and that session also is needed because all these critical comments and they have long-term consequences which parents don't realize. And they take it for granted, like somebody said, कि एक थप्पड़ लगा दिया तो फिर क्या हुआ? But वो दिखता नहीं है emotional abuse, but it has long-term consequences.
The parents should ask them to study harder
Instead of saying कि हाँ, instead of realizing the mistake that तू अच्छी तरह पढ़ ले, so you won't be able to, you won't face all this. They have poor understanding of an intellectual, maybe greater expectations. Let me close the session.
Any concluding remarks?
We had a good discussion and we had good participation, and I think everybody was happy with the way we dealt with the things.
Thank you everyone for your active participation. I would now request Professor Savita Malhotra ma'am to kindly give a token and appreciation to Professor Adarsh Kohli ma'am. Now allow me to welcome the organizing committee to come forward for conducting the valedictory session. Dr. Akhilesh sir, thank you.
थैंक यू हिमानी। हमारा लास्ट सेशन अब ख़त्म हो गया है, तो इस वर्कशॉप के ऑर्गेनाइजिंग सेक्रेटरी के नाते मैं आप सभी का बहुत बहुत धन्यवाद करता हूँ, क्योंकि जो भी हमारे पार्टिसिपेंट्स हैं वो काफ़ी दूरी से आए हैं, उन सब ने बहुत ही समय से रजिस्ट्रेशन किया और आप लोगों के बिना ये प्रोग्राम संभव हो ही नहीं सकता है, तो मैं आप सबका बहुत बहुत धन्यवाद करता हूँ। दूसरी बात ये कि आप लोग बड़े ही एक्टिव पार्टिसिपेंट्स रहे हैं, बहुत ज़्यादा पार्टिसिपेशन रहा है और इस वजह से ये प्रोग्राम ज़्यादा इंटरेस्टिंग हो सका है, क्योंकि अक्सर क्या होता है, जैसे हमारे काफ़ी प्रोग्राम्स होते रहते हैं, बहुत बार ऐसा होता है 50% से ज़्यादा में कि कोई सवाल जवाब कोई पूछता नहीं है, तो उसका फिर कोई सच में मज़ा नहीं आता है, ना जो लोग प्रिपेयर करके आते हैं टॉप के लिए और जिनको सीखना होता है वो भी नहीं हो पाता। तो ये सब आपके द्वारा ही संभव हुआ है, तो आप सब जो है बधाई के पात्र हैं। तो एक अपने लिए दूसरा हो सकता है इस दौरान हमारे पास जो भी लिमिटेड रिसोर्सेज थे उससे हमने अपनी जानकारी में, अपनी क्षमता में बेहतर से बेहतर करने की कोशिश की है, पर कोई भी चीज़ हमेशा बिल्कुल परफेक्ट नहीं हो सकती। तो अगर हम लोगों से कोई कमी या त्रुटि रह गई हो तो उसके लिए हम आपसे क्षमा चाहते हैं। कई बार मैंने बीच में आप लोगों को रोका भी है फोटोग्राफ लेने से या डिस्कशन से, क्योंकि प्रोग्राम को समय पे ख़त्म करना होता है, तो उसके लिए मैं क्षमा प्राप्त हूँ। हमारा जो भी कोई प्रोग्राम करते हैं 2016 से हमारे विभाग के अंदर हर साल में 2 बार प्रोग्राम्स करते हैं और ये प्रथा हमारे डिपार्टमेंट ने जो शुरू की है, और हर बार जब भी हमारी फैकल्टी जो है वो हमें मौका देती है सारा ग्रुप, तो इस बार मैं हमारे सभी फैकल्टी मेंबर और हमारे विभाग के अध्यक्ष डॉक्टर देवाशीष बासु जी का आभारी हूँ कि उन्होंने पहली ही बार में जब डॉक्टर नीली ने ये प्रपोजल दिया तो उन्होंने हमें स्वीकृति दी, और जब भी हमें कोई उनसे मदद चाहिए होती है तो 10 सर को जो इंग्लिश में बोलते हैं, यू आर जस्ट ए कॉल अवे, और ये बात बिल्कुल सच है। मैं उनका फ़ोन नहीं उठा सकता, पर सर आप हमारा फ़ोन तुरंत उठाएंगे और कभी भी हम उनके ऑफिस में जा सकते हैं, ये समस्या है। और उस वजह से क्योंकि फिर हमको बहुत सारा एनकरेजमेंट मिलता मिलता है कि आप हमारे साथ हैं और हम अपना काम कर सकते हैं। तो सर हम आपके बहुत बहुत आभारी हैं। इस प्रोग्राम के लिए हमारे जितने भी सीनियर हमारे फैकल्टी मेंबर्स हैं जो रिटायर हो गए हैं, जो पुराने विभागाध्यक्ष हैं, सभी के पास अपने अपने कमिटमेंट्स हैं। अभी भी सभी लोग काफ़ी अपने अपने स्तर पे बहुत ज़्यादा काम कर रहे हैं, तो भी उन्होंने, और प्रैक्टिसिंग साइकेट्रिस्ट के लिए वीकेंड काफ़ी व्यस्त होता है, फिर भी सभी ने अपना बहुमूल्य समय निकाला और हमें ये दिखा दिया कि अभी भी वो बिल्कुल टाइम से 5 मिनट पहले आते हैं। हम लेट हो सकते हैं पर आज भी वो भी उन्होंने हमें एक सबक अभी भी देते हैं। तो मैं सभी का आभारी हूँ कि सभी लोग आए। हमारे फॉर्मर डीन और हेड ऑफ द डिपार्टमेंट प्रोफेसर सविता मल्होत्रा अभी भी बैठे हैं, तो मैडम हम आप सबके आभारी हैं। डॉक्टर आदर्श कोहली, और जैसा कि मैं आप सभी जानते हैं, परंतु अगर मैं हमारे कार्यक्रम के सूत्रधार जो हैं प्रोफेसर शेखर शेषाद्री, जो कि बहुत ही फेमस टीचर हैं, जो चाइल्ड मेंटल हेल्थ के लिए, चाइल्ड साइकेट्री में बहुत से मेरे से भी बहुत से सीनियर लोग जो भी ट्रेनिंग के लिए जाते हैं, इवन साइकोलॉजिस्ट, सोशल वर्कर, जो भी विभिन्न क्षेत्रों में निमैंस जाता है, अदरवाइज कौन सर से परिचित नहीं है। और सर की महानता ये है कि उन्होंने एक बार ही कहने पे, मतलब इतना ज़्यादा उनका कमिटमेंट होता है। अभी मेरे को एक स्टूडेंट कुछ पूछ रही थी हमारी, तो मैंने कहा आप सर से पूछ लो अगर वो मदद करेंगे, तो भी उन्होंने दिखाया, पूरा शेड्यूल भरा हुआ है, फिर भी उन्होंने कहा कि मैं आपकी जिस भी कैपेसिटी में मदद कर सकता हूँ आप मुझे भेजिए। तो सर ने बिल्कुल हमें पूरा सपोर्ट दिया और हमारे ऊपर किसी प्रकार की कोई भी, मतलब इतना हमें फ्री कर दिया कि हमें लगा कि बस अब ये प्रोग्राम, क्योंकि ये टॉपिक ही ऐसा था जो सर के बिना संभव नहीं था। तो हम तहे दिल से आपके आभारी हैं और हम खुद को भाग्यशाली समझते हैं सर कि आपके साथ प्रोग्राम को सफल बनाने के लिए हमारे विभाग के एसए, सफाई कर्मचारी, एचए, वहाँ से मैं शुरू करूँगा। फिर हमारे जो भी स्टूडेंट्स हैं, चाहे वो पीएचडी के हों, चरण एमएल और अमरीना भुल्लर अभी नहीं है यहाँ पे, हमारे सारे जो रेजिडेंट डॉक्टर्स हैं, डॉक्टर हिमानी आदर्श, वहाँ डॉक्टर वीएल प्रशांत खड़े हैं, डॉक्टर गायत्री राजन, और हमारे जूनियर रेजिडेंट डॉक्टर नम्रता, डॉक्टर देविका जी, और हमारे सीनियर रेजिडेंट डॉक्टर प्रियंका पिलानिया, हमारे साइकोलॉजी के करीब जो प्ले थेरेपिस्ट हैं दीक्षा सचदेवा जी, सतविंदर सिंह सैनी जी, हमारे सोशल वर्क के जो कलीग हैं कृष्ण कुमार जंजोत्रा जी, और मेरे साथी फैकल्टी मेंबर डॉक्टर निधि, डॉक्टर रंजीत पिल्लई पीछे खड़े हैं शर्ट के अंदर, डॉक्टर देवेंद्र राणा जी और डॉक्टर किशन सोनी जी। इन सब ने बहुत ज़्यादा मेहनत की है। डॉक्टर किशन सोनी और डॉक्टर निधि बिल्कुल लगे रहे, हालांकि मेरे को उन्होंने ऑर्गेनाइजिंग सेक्रेटरी का सम्मान दिया है। मैंने कुछ ज़्यादा काम कुछ भी नहीं किया, मुझे कुछ पता भी नहीं चला कि ये सब कैसे हुआ है, और उन्होंने मेरे को मौका दिया है और अब भी मेरे को आगे किया हुआ है। तो मैं आप सबका बहुत आभारी हूँ और मेरे को गर्व है कि मैं आप सबके साथ काम करता हूँ। अंत में मैं आप सबसे कुछ, मतलब लिमिटेड है, अगर एक दो लोग अपना फीडबैक हमें देना चाहें कि आगे हम अपनी बेहतरी के लिए कुछ और क्या कर सकते हैं, क्योंकि हर साल हम 2 प्रोग्राम्स कराते हैं, तो अगर कोई चाहे तो अपना फीडबैक दे सकता है। जी
जस्ट वन थिंग सर, अगर कोई ग्रुप या कहीं, सो दैट वी नो कि कौन से प्रोग्राम्स हो रहे ट्वाइस अ ईयर। अभी जैसे आई केम टू नो थ्रू समवन, बट पीपल हु पार्टिसिपेटेड, अगर हमें वो इंटिमिटेशन हो जाए कि इस मंथ में ये हो रहा है, इफ जस्ट दैट मच कि आगे के प्रोग्राम्स के लिए वी नो व्हेन दे हैपनिंग।
बहुत ही आपने बहुत अच्छा सवाल पूछा और हमें भी जगा दिया। हमारे विभाग के अंदर, हमारे विभाग की जो स्थापना का दिवस है उसका गोल्डन जुबली प्रोग्राम होता है, जो कि इस बार 14, 15 और 16 सितंबर को हो रहा है। फाउंडेशन डे में डायमंड जुबली प्रोग्राम है, और ये प्रोग्राम जो है ये एक इंटरनेशनल कॉन्फ्रेंस है और इसकी थीम बहुत बड़ी है, पब्लिक मेंटल हेल्थ फॉर ऑल, मेंटल हेल्थ फॉर ऑल पे। और जो है इसके अंदर हम सभी क्षेत्र से लोगों को इनवाइट कर रहे हैं, जो इंडिया के अंदर जो वेरियस ऑर्गेनाइजेशंस हैं, चाहे वो क्लिनिकल साइकोलॉजिस्ट की हो, सोशल वर्कर्स की हो, नर्सिंग की हो, चाइल्ड मेंटल हेल्थ प्रोफेशनल्स की हो, चाहे वो साइकेट्रिक सोसाइटी हो या सोशल साइकेट्री की सोसाइटी हो, वो सभी इसमें सपोर्ट कर रही हैं और वो सब भागीदार हैं। और साथ में ये प्रोग्राम का काफ़ी जो है इंटरनेशनल एक्रेडिटेशन भी शायद हमें मिल जाएगा वर्ल्ड साइकेट्रिक एसोसिएशन की तरफ से, जिसका एक एक्रेडिटेड सेंटर जो है हमारे विभाग अध्यक्ष के प्रयास से हमारा डिपार्टमेंट बना है। तो हम उम्मीद करते हैं कि आप सब लोग इसमें भी पार्टिसिपेट करें। इसके काफ़ी अच्छे पॉइंट्स मिलेंगे, बहुत मतलब उम्दा और अपने क्षेत्र के आला जो स्पीकर सब लोग इसके अंदर आएंगे। हमारी इसकी वेबसाइट है डिपार्टमेंट की और वो लॉन्च हो चुकी है, वो हम आपसे शेयर करेंगे। और इसका जो अर्ली बर्ड जो रजिस्ट्रेशन है वो 30 जून तक है और मैं उम्मीद करता हूँ कि आप सब इसमें भी पार्टिसिपेट करेंगे। धन्यवाद। कोई और कुछ कहना चाहता है? सर
994 है मेरा चाइल्ड शेकर का, 6 और 2 ताकि मेरा 1000 का हो जाए।
एक बार मैं इसी के साथ आप सबका बहुत बहुत धन्यवाद करता हूं और जाने से पहले एक गर्म चाय या कॉफी का प्याला आप जरूर लेते हैं। और अपने जो सर्टिफिकेट्स हैं वो आप आराम से कलेक्ट कर सकते हैं, सभी के तैयार हैं। जो भी मेडिकल डॉक्टर्स थे उनका पीएमसी से एक्रेडिटेड है और जो हमारे साइकोलॉजी के और अन्य कलीग थे उनका रिहेबिलिटेशन काउंसिल से एक्रेडिटेड, तो आप ले सकते हैं। और अगर किसी का कुछ दिक्कत भी आती है, कुछ छपा नहीं है, मिस होता है, तो हम उससे उपलब्ध कराएंगे। धन्यवाद। थैंक यू।
यस सर, लुक क्या
हमारा बैनर आ रहा है ना पीछे?
यस मैम, आ रहा जी। वेट। ओके, थैंक यू।